Good afternoon, dear colleagues. My presentation is very simple. Okay, I'm not going to show you a lot of studies because I know this was a parallel section, so I thought that maybe there are students, there are residents. The question is, seems that I have the same problem with the slides. The question is, can we treat patients with locally advanced rectal cancer without surgery by using total neoadjuvant therapy? I think all of you know what total neoadjuvant treatment is. Is this working? No. Okay. Total neoadjuvant treatment, as you probably know, is the anticipation of chemotherapy before surgery. The standard treatment for patients with locally advanced rectal cancer has been for decades chemoradiation, and then surgery, and then chemotherapy. Total neoadjuvant therapy means we anticipate chemotherapy before surgery. Sometimes we use before chemoradiation, then chemo, then surgery. Sometimes we start with chemo, then chemoradiation, and then surgery. Can we use this non-operative management? They started in Brazil in the 90s to try this approach. We use chemoradiation, and we see. If we see a complete clinical response, we just follow the patient, and we treat patients with surgery only in case of tumor regrowth. Okay, is it allowed today? Today the guidelines are saying, yes, we can, provided some conditions, and the conditions are multidisciplinary management, because to evaluate these patients before and after treatment, we need radiology, meaning MRI. We need gastroenterologist, meaning endoscopy. We need a good physician. You know what I'm talking about. Digital rectal examination. And let's say it's in my opinion, it's not just have a multidisciplinary team, it's also the quality. The quality of interpreting an MRI is not the same. If you have a dedicated radiologist, the thing change a lot. And the second condition is we need a patient committed to have a very strict follow-up. See, practically, if you have a patient coming from a far village, from the north of Bangladesh, who will never come back in your hospital, no watch and wait strategy for this patient, because you cannot follow. I will show you that the follow-up has to be very intensive in these patients. Which patient we can avoid surgery? For years, the definition was clinical complete response. Things changed because when Abrahama started in Brazil in the 90s, she was using the finger, she was using ultrasound. Now what is required is a negative endoscopy. Okay, after chemoradiation and the chemo, you can see some little scar. You can see no, you cannot see on endoscopy anything. No ulceration, no nodules, no stricture. On digital rectal examination, you can just feel a scar, but flat, no nodules. And the MRI should be practically negative. Okay. Something changed about these definitions, and something is changing about the assessment. Okay, we said We treat the patient with radiation and chemo, then we evaluate, and then we go for surgery. When should we evaluate the patient? How many weeks have to pass from the end of treatment and to the evaluation of the patient? Things are different depending by the scheme you are using. Because consider that rectal cancer are strange. They grow very slowly and they respond very slowly to radiotherapy. Meaning, if you start with chemo, followed by radio, you have to wait almost 8 weeks before restaging. But if you start with radiotherapy, followed by chemo, radiotherapy has the time to act. And so you can wait even less than 1 month before restaging the patient. Is it clear what I mean? Is it clear? So the restaging depends by the scheme you are using. Then something new happened in the last years, the definition of near complete response. What is near complete response is close to a complete response, meaning some very small irregularities at ultrasound, not ultrasound, sorry, MRI, digital examination, and endoscopy. Why they define that? Why should we consider these patients? Because in these patients with a strong response, but not complete response, maybe just a matter of time. If we wait some more week, maybe we will reach a complete response. And this happened. This happened. In this patient, you can evaluate, is it complete? No, it's near complete. Wait 8 more weeks. Because in few weeks, things can change. Look here, the percentages of complete pathological response are, this slide has completely changed, but are, if you evaluate after 6 weeks, is 12%. If you evaluate 12 weeks, it's 23%, it's double. If you evaluate after more than 13 weeks, it's 13. You cannot read it, but trust me, it's 31 actually. So it makes sense to consider also near complete response. In this patient, just wait some more week. Obviously, all patients without complete, without near complete, or patient who had complete and then had tumor regrowth had to go for surgery. This is obviously. Follow-up, this is what I was saying before. Patients have to be reliable and very committed to undergo for a very strict, very strong follow-up. You see the timing. The first 2 years, the patient has to be re-evaluated every 3 months. The following 3 years have to be evaluated every 2 times a year. And this is, I think, very demanding. Consider to have 3 MRI every year. So the patient has to be committed and has to be ready to undergo this kind of follow-up. Then we were saying, is it possible to use total neoadjuvant therapy? Total neoadjuvant therapy, we are not going deep here. There are a lot of studies. These studies are different in terms of results. It's different to compare them. Also because if you see the treatments are very different. RA means response assessment. You see the timing of response assessment is completely different from one study to the other. Time of operation is different, so it's difficult to compare them. As total neoadjuvant therapy acts is not completely clear. The important part is that it works. But just to do you an example, we thought for a year that, after this study, it was clear something. Chemoradiation, U-weight resection, complete pathological response, 18%. Chemoradiation, 2 cycles of chemo, increased pathological response. Chemoradiation, 4 cycles, increased. Chemoradiation, 6 cycles, increased. So it seems that more chemo means increased rate of complete pathological response. Is it true? Because in Italy, we did an analysis on 2,000 patients. They were treated with chemoradiation and only surgery with different interval times. And we saw that patients resected after more than 13 weeks, they had more than 30% of pathological complete response without chemo in the middle. So is it chemo or is it just time? Something is not completely clear. But at the end of the day, what we are interested about is that total neoadjuvant therapy works. I'm not talking you about several trials, just 2 trials. The one who introduced definitely in guidelines the total neoadjuvant therapy, the Rapido trial, short course chemo resection against standard chemoradiation, surgery and chemo. Some difference in the Prodige. In this kind of study, they started with total neoadjuvant was based on chemo, standard long course, not short course, long course, not radio, not chemo followed by radio. Here is radio followed by chemo, and the same control arm. What happened? Okay, the 2 studies have some small difference. In the Rapido trial, there are more T4 compared to the Prodige study. There are more patients with involvement of the mesorectal fascia compared to the Prodige. But both studies had positive results. Compared to the standard treatment, that is standard chemoradiation, concurrent chemoradiation preoperative, there is an improvement in disease-free survival in TNT in both studies. There is a same local regional failure, some improvement in distant metastasis, same overall survival, but a clear, strong improvement in terms of complete pathological response, which makes total neoadjuvant therapy very good in terms of organ preservation. So the possibility in this case is high. So NCCN, they say low risk patients, clear circumferential rectal margin. TNT is the preferred therapy, even though the standard approach is still possible. And in these patients, we can use non-operative approach, okay? As always, in selected center, in selected patients. And in high-risk patients, the one with involvement of the circumferential rectal margin, or T4, or locally unresectable disease, TNT, total neoadjuvant therapy, is the only recommended treatment. And also in these patients, in selected centers, in selected patients, we can use non-operative approach. The only question remaining is, should we start with radio or should we start with chemo? Because the 2 studies had 2 different approaches. And the answer comes from this other trial that you know very well, where they compared chemo followed by radio and radio followed by chemo. The results were very simple. If you start with chemo, the percentage of patients without surgery is 41%. If you start with radio, the percentage is 12% higher. So it seems that starting with radio, when possible, is the right choice. No other difference with other endpoints. Lastly, Professor Sumon asked me, but the selection. Obviously, the selection is based on the response. But if we want to have a rough idea before starting the treatment, who is the good candidate, who is the bad candidate for organ conservation? It depends. Consider a patient with a low rectal cancer, candidate for abdominal perineal resection. But the tumor is small, it's not large, it's not circumferential. There are no nodes. Okay, in this case, I have an high possibility to complete response and a high advantage for the patient because I can avoid abdominal perineal resection. On the contrary, consider a patient with a high tumor but very large, circumferential, maybe mucinous, maybe with positive nodes, but is not candidate for abdominal perineal resection. Probably this is the worst candidate for organ conservation because we are not avoiding large surgery and because the probability of complete response is practically gone. I have finished. So TNT-based watch and wait policy is possible, can reduce our 50% the rate of patients operated, only in selected patients and in selected centers. Thank you very much.